Ladies and gentlemen, buckle your seats because this, I want to hear back from those who are in Africa. I'm excited about this. I really am. Thank you so much.
So I'll just start by introducing myself. Good afternoon, everyone. I'm Dr. Bert Petersen. I am a cancer surgeon and a breast cancer specialist. I'm based in New York City. I was born on the island of St. Thomas in the Caribbean. And part of my background, I actually built and developed the first comprehensive cancer center in the Caribbean, which opened on the island of St. Thomas in January of 2005. And my company, Africa Cancer Control Partners, right now is working on and developing the first modern state-of-the-art comprehensive cancer center on a large scale. And in my slides, I will show you an example of that when that time comes in sub-Saharan Africa, and is slated to open in Accra, Ghana. So that's a little bit about myself.
Pleasure. Thanks for having me, Keith, and pleasure to meet you all. Yusuf Henriques, founder and CEO of IndyGeneUS. We're a precision genomics company looking to look at health disparity at the molecular level. And so we have been diligently working the last 2.5 years to build a biorepository of over 1 million diverse data set biobank. And so our first lab will be open March, April of 2025 in South Africa, Johannesburg, where we're building a state-of-the-art genomics lab so that we could sequence samples from the African diaspora so that we could build better diverse cell and gene therapy as we start to move into precision medicine and health equity. Pleasure to meet you all.
So I'll make this brief in the interest of time. Can we have the next slide, please? I always start with this quote, which I know everyone probably on this call has heard, but I think it's important, especially as Yusuf said, when we start to deal with disparities in healthcare, when Dr. Martin Luther King Jr. said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Next slide, please. So let me just start by saying I first came to the continent in 2005 to present what I am now presenting to you as well in its more mature form. But part of why I came in 2005 is because one of the things that I started to recognize that this slide is pointing to is the fact that Africa has had a false narrative for many years now, where Africa is related to as a continent only of communicable diseases, primarily TB, malaria, HIV, when in fact, over time, and you can see the predictions from this slide by 2040, and currently right now, there are more people dying on the continent from cancer than AIDS, TB, and malaria combined. And while the communicable diseases are getting treatment and people are doing better, there's almost no care, very little care that's required for patients who are now developing cancer on the continent at an alarming rate. Next slide, please. And this becomes particularly important, and I'm going to relate this to the work that Yusuf is talking about. When you look at certain cancers, let's just take prostate cancer, for example, in Black men. We get prostate cancer sometimes at 4 times the rate of every other racial and ethnic group. Yet we are grossly underrepresented in research trials looking at the cause, the underlying cause for this. And one of the things that I recognized back in 2005 as a young physician, watching the trend of what was happening to medicine, is that if we didn't start to look at our DNA, and cancer is a disease of the genetics and of the genome, if we didn't start looking at our genetics, we were going to miss the boat. And so part of what was important for me was that whatever we did, first we had to come back home to where we're from. We had to look at our DNA and our genome to better understand this. We needed to be more participatory in clinical research. And one of the things that's happening on the continent right now is that there are very few tumor registries actually even collecting data on the true magnitude of this problem. Next slide, please. And this is particularly glaring when you look at what's actually happening, because we know that it's grossly underrepresented in Africa, the number of cases. But even with what data we have, the United States has 5 times the amount of cancer cases as opposed to Africa. But if you look at both sides of this graph, what I want you to notice is that on the Africa side, in many cases, the green is the same length as the blue, which means that most people who get cancer in Africa are actually dying of the disease, whereas in the United States, more people are actually living. So for example, with breast cancer in Africa, it's about a 15% survival rate as opposed to 98% survival rate in the United States. Next slide, please. And this slide just continues to show that it's not just throughout Africa, but West Africa actually seems to be doing worse than Africa than the continent overall. And again, like I said, more cases in the developed world, but people are dying at an alarming rate in Africa and in West Africa. Next slide. And equally alarming is that the trend is not predicted to slow down. It's actually going to get worse. So by 2040, the African continent is going to continue to lead the world in the highest incidence, meaning the highest number of new cases, the rate at which new cases are developing in cancer. And that rate is predicted to be about 89% increase. And when you look at regions across the globe, you'll see that where Black and brown people live are the highest areas. Latin America and the Caribbean, where many of us got dropped off on the way over, 66% increase, Asia 59% increase, and the white areas of the world, the rate is much lower. Next slide. And not only is the rate higher in terms of new cancer cases, what's even more alarming is the death rate. In Africa, the death rate is expected to increase by about 93%, almost 100% increase in the death rate by 2040. And again, this is replicated in all of the areas where Black and brown people live, like Latin America and Caribbean, which came in second at 77%. Next slide. And in the West Africa sub-region, we're expected to see a growth of over 500,000 new cases over this time period. And if we do nothing about this, we're looking at losing another over 200,000 people. These are 200,000 avoidable cancer deaths that we should expect if we do nothing about it. Next slide, please. So I want to talk about, now I've talked about the problem in terms of the disease aspect. Now here's the problem that we are facing and why people like Yusuf are important in the answer to this problem is the lack of infrastructure. If you look at the West African sub-region, and if we just take the top 3 markets, Nigeria, Ghana, and Cote d'Ivoire, there are only about 350 radiologists in those 3 countries, 350 radiologists, only about 98 clinical oncologists, and about 163 pathologists. This is about less than 10% of the required specialists to actually deal with this issue in West Africa. In West Africa and across Africa, for that matter, there are about 2 surgeons per 100,000 people. In the United States, you're looking at 35 to 40 surgeons per 100,000 people, which means most surgery is not being conducted by trained surgeons. There are very few chemotherapy drugs available, and they're so expensive because the African market has to compete individually on its own as opposed to a collective market. But one of the greatest atrocities when we look at this issue of cancer in Africa, because so many people are being diagnosed at much later stages because of the lack of care and the lack of access to screening, you really require radiation therapy to treat cancer. And 29 of 52 African countries, listen to what I just said, 29 of 52 African countries have no access to radiation therapy. In the United States, the machine that delivers radiation therapy is something called a linear accelerator. We have 1 linear accelerator for about every 250,000 people in the United States. Ghana, with a population of 30 million people, has 3 linear accelerators, 2 of which we would never use in the United States, and only 1 would meet our international standards for treatment. 1 machine for 30 million people. Next slide, please. So what we're proposing is a very comprehensive, next slide, is a very comprehensive model. Melvin, next slide, please. There should have been a slide before this. Was that slide before this, Melvin? Yeah, a very comprehensive model that includes education and research, prevention and screening, and optimal care delivery, a team-based ecosystem where we are bringing a comprehensive team to this problem, contemporary care with the latest equipment and the latest technology, and an effective organization. And what that looks like, next slide, is what we like to call our cancer village. You know, it takes a village. And this includes on the scale of what we would have in the United States, like a Sloan Kettering, a Johns Hopkins, or an MD Anderson, where there is the cancer hospital here in the center, the outpatient treatment facility, all of the support services, the teaching and training that will happen. We have been granted 50 acres of land as from the Ghana Atomic Energy Commission. And so we would be working with them to train the workforce of the future in this training and development facility. There'll be housing access for not only doctors and nurses, but if you're coming from Togo and you need radiation 5 days a week for 4 weeks, you're not going to be flying back and forth to Togo every day. Where will you stay? We'll have housing here for patients that are coming in. And something that is badly needed in Africa is hospice care. And for me, the exciting part of this project, because if you're going to do anything when it comes to cancer care and cancer treatment, you've got to do research. And this is the synergy between what Yusuf and I are both at work on. And that is, you cannot do any work in the field of oncology if you're not looking at genomic medicine. The future of medicine, period, but specifically in cancer, is in genomic medicine. It's all about targeted therapy right now. And I'm just going to leave one quick example of what I'm talking about. 10 years ago, triple negative breast cancer, which I would say is overexpressed in Black women. We found triple negative breast cancers in Ghana, in the Caribbean, same cell type, and in the United States of America. These women usually died within a year of their diagnosis, because many of them, they were very aggressive tumors. Because of genomic medicine and actually studying these cancers, there are new treatments on the market right now, targeted therapies, where as a surgeon, I am diagnosing these women, they're getting treated, and then I take them to the operating room. And when I do surgery, I can't find a cancer in the specimen that I'm taking out. I can't find a cancer in the lymph nodes when we knew it had already spread to the lymph nodes. That's the importance of the kind of work that Yusuf is talking about that is critical if we're ever going to advance ourselves in the treatment of cancer, but particularly to understand its uniqueness among people of African ancestry. We've got to go look to our DNA, and we've got to study these diseases on that level so that we can have the advances and breakthrough in treatment that we're looking for. And then lastly, the last slide, I'm just going to end with, I've been told for years, too big, leave it alone, this will never happen. And I'm just going to end with Nelson Mandela's quote, "It always seems impossible until it's done." So thank you, and I look forward for your questions and comments later. Thank you.
I have an opportunity to look at my past, my present, and my future. That's what whole genome sequencing does for you. It tells you your genetic, your history, but then it also tells you where you are in this moment. What are you predisposed to? Then based off of that, you can make predictions on what your future will look like. Knowing that information on the front end, instead of being reactive to it, that's why this is so personal to me.
Preventative access can create a domino effect on the rest of your health. So oftentimes, if you don't have prevention or just screenings, which are done, you fall by the wayside. And unfortunately, underserved communities are not getting the preventative and screenings that they should be. Prevention and just insights would be important going forward. So genomic sequencing is the first step to give us these insights and to help us to know what's going on, at the cellular level.
The mission for IndyGeneUS is really to drive precision health equity. We understand now the magnitude of what diversity means as we move forward into the world of precision medicine. We're not going to be able to go back and fix the drugs that are on the market. But these new therapeutic areas are pretty brand new, where we don't have to start off where we left off, but we could actually build something that could be a lot more inclusive.
Indigenous AI is really leveraging multiple technologies for the benefit of traditionally underserved and underrepresented populations. First of being next generation sequencing and whole genome sequencing. And it holds the key to what's driving disease or their risk for disease later on in life. Second technology that we're utilizing is artificial intelligence and machine learning. As of October 6, 2022, the Cures Act has given every citizen free access to their digital health records from anywhere they receive care. And this is important because this technology is able to tease out insights from this data in combination with the genetic data and other family health history data that we collect. And the last technology that we're leveraging is blockchain technology to secure an individual's data and give them the control and management and also the transparency into who's viewing and utilizing their data to facilitate trust from populations who have historically not had a great deal of confidence or trust in the medical system.
The patients will now own the data. This has never been done in healthcare, and oftentimes big pharmaceutical companies are profiting from data from all of us. And so at IndyGeneUS, we want to give that ownership to the individuals, and so they'll be able to sell their data if they wish, and then produce actionable insights from this data, which will help them and many others to come.
We've created a platform where individuals can bring their genetic data as well as their health data and securely store it and have control over that data and control who has access to it. This will give them the opportunity to participate in research projects if they so choose, and or potentially clinical trials. We see that the overwhelming majority of participants in those trials have been Caucasian males. Without a diverse population or a diverse set of participants, there can be some adverse reactions or some toxicities that get missed that occur in certain populations that don't occur in others.
We at IndyGeneUS are helping to improve research and improve diversity within research by getting samples of people that are indigenous to the land, whether they're Black, Brown, Pacific Islander. We're getting insights on all ethnic groups, and so we can aggregate the data and get very significant insights on treating those groups going forward.
We can't be looking at precision medicine as a localized public health crisis. This is now a global mission. And so IndyGeneUS was set up that way. So we are looking to expand in Africa quite quickly, in South Africa, Ghana, and Kenya, simultaneously as we are here in the US. So right now IndyGeneUS is at that first phase where we're trying to create a repository on the blockchain that will encompass large data set of women, minorities, so that we'll have a reference library, so that we'll have better understanding of how some of these disease areas are evolving and how IndyGeneUS could evolve and be ahead of whether it's the pandemic, pathogens, or looking at new disease targets and gene targets that we could come up with better efficacious drugs globally.
I am
IndyGeneUS AI. Good. So to piggyback on what Dr. Petersen said as the slides come up, extremely important the work that he's doing. The lack of diversity in clinical trial has created a critical mass and a critical need for the work that he's doing. Just, again, one area is cancer. There are multiple other areas that, again, this work that is being done in the cancer center that he's developing, they could then, with genomic sequencing, as we start to look at your whole genome, could start to look and identify other conditions that individuals may be susceptible to. And so, when we started to look at this, when I was working with the VA Department of Veteran Affairs, we used
Holocaust survivors and World Trade Center survivor bloods to look at your susceptibility to PTSD using emerging technologies like next-gen sequencing and AI machine learning. And so it was very powerful and compelling to see how we could now, over 20 years since the human genome has been sequenced, to really identify genetic targets, as Dr. Petersen mentioned, and being able to look at diverse data sets so that we can find better targets, so we could come up with better, therapeutics like cell and gene therapy. Next slide. So again, this is a team at IndyGeneUS. We're all Howard University graduates. Dr. Wilson and Dr. Taylor are from my first company where we built a blood test using next-gen sequencing technology, which is genomics, to look at your predisposition to PTSD. Eric Williams, also a Howard grad, is our Chief Technology Officer, and Angel Livas rounds out our team. And so we have about 80, years of experience working in the biopharma, cell gene therapy space. Dr. Wilson is actually a trained geneticist from Howard University. Next slide. We also recognize that it's going to take a village. And so as you can see, this was intentionally done and having strong advocates and advisors within the women's health space that we're looking to make sure that, as Dr. Petersen mentioned, around triple negative breast cancer, Dr. Cameron Matthews, who was formerly the chief medical officer of the VA, is now at City Block. Dr. Walla, which is at Kenya Healthcare Federation, and Dr. Emily Backer, who is at Moderna. So we've gone out and seek advisors in the women health area that we look at PCOS, endometriosis, uterine fibroid, and also mentioned in South Africa. And the quote that Dr. Petersen named, Nelson Mandela grandson Zanwa Mandela from the Mandela Legacy Foundation also sits on our board so that we're looking at the work that we're doing within South Africa so that we could drive this health equity and diversity within the genomic space in our lab in South Africa. Next slide. So again, I want to just highlight how important this is. Why does this matter? And this is a slide that's very, that details that diversity in genetics and sequencing is a high need right now in multiple disease areas that affect Africa. The lack of diversity is now really driving where Africa is less than 2%. Somebody puts up, there you go. The lack of diversity in the clinical trials has really provided a groundswell of why Africa is so important. Ghana, Kenya, South Africa, it's very important that diverse data set get included in the biobanks that are being created. And then there's a regulatory tailwind that the FDA now recognizes that we cannot keep developing cell and gene therapy and precision medicine with an 88% European white male data set, which is currently what every pill in your cabinet has been developed using participants. And so, what we see now is the compelling argument to drive not only the diversity, but also get the African continent involved. And I do believe in the next 5 to 10 years, as Dr. Petersen mentioned, Africa will be a groundswell where a lot of innovation within the healthcare space will be at the forefront of precision medicine and driving some of the novel gene targets and therapies that are going to be required, not just for Africa, but for the globe. Next slide. And so, what we've done is we've provided a platform that we understand the privacy and security, where we've worked with Google and other technologists so that we could create a platform where once we sequence the genetic material, we have a way to provide that privacy and security, which is very important within our Black and Brown community. And so here's what you see is where we've been able to create a platform with blockchain. We'll be able to provide immutability and the ability to provide transparency to the participants, and also knowing where their samples have been shared and what type of therapies their samples have been contributing to. And so we do solidly believe that this is the platform that will be able to drive more participation and reduce the lack of trust that currently is within our communities around providing blood samples and getting involved in healthcare and research and development and clinical trials. Next slide. So just talking about the huge opportunity. So KPMG worked with us to develop these. If you just look at this from left to right, as what Dr. Petersen mentioned, we're talking about that clinical genomic data to find gene and cell and therapy targets. Big industry, still growing every year as these slides, which are probably about 6 months old, it might have even doubled since then because of the need for these type of therapies. The clinical trial, I think Keith and the team have highlighted how important health equity and clinical trial participation is, and so that's also a vertical. And then even direct to consumer, being able to have patients, provide their samples and their biospecimen so that they can contribute to science. Because again, the quote that I like to use, if you're not at the table, you're going to be on the menu. And so this is a critical time for our community, both in the US and in Africa, to be more engaged in clinical trial, be more engaged in their care, and be able to contribute to science. But we also want to protect that information and data. And that's what IndyGeneUS is looking to bring, that end-to-end solution to drive the type of therapies that, cancer centers like Dr. Petersen is building will be able to do that on the continent and not off the continent. Next slide. And so if you're wondering where the frenzy is at right now, about November 2023, the UK Biobank, which is the largest data repository of whole genome sequencing that was aggregated, unveiled that what I knew 4 years ago, that they're 88% white. And so less than 12%, 10,000 African diaspora, and the rest across Asian, Hispanic. So literally 60,000 out of 440,000 white participant, only 60,000 of the minority community of a 500,000 human genome. And so since then, you've seen pharma now have been chasing to find more aggregate of African diaspora samples across the globe. And so these are two initiatives that's been launched by huge pharmaceutical companies to develop biobanks in the US, but they've, again, left Africa out. And so IndyGeneUS working with Orem will be the third slide that you mentioned that will be presented here, that where we're creating the same groundswell, building that reverse, that 88% African diaspora, Indian, Asian genetic population, so that we could drive the drug discovery and get pharma to come to the table the same way that they're looking to work with these precedent deals that they've done over the last 6 months. Next slide. And so I mentioned our Orem partnership. This has been huge because we've been able to work with Orem, which is a large clinical research organization in South Africa. And they have now built the trust and credibility that USAID have now trusted them with the first 150,000 samples of aggregated African genome that was originally stored in the UK. Those samples now are on the continent. But what that does is it provides that credibility. Same way Dr. Petersen is building credibility in the cancer space and industry. This now makes Orem a premier location to store samples of all diverse African diaspora, and also be able to have the ability to go after large contracts with doing some of the genomic sequencing that's going to be needed, so that we can look at genetic targets across the population. Next slide. And so, yeah, the business model for us is pretty simple. You've seen the verticals. We have the next-gen sequencing as a service, direct-to-consumer testing, clinical trial recruitment, and regulatory consulting. And so we really do believe that from a global partnership standpoint, we want to grow this biobank into, again, Orem has the capacity to store up to 3 million samples at this location. We want to build other locations. We've built traditional partnership and strategic partnership with a large pharmaceutical company, Riker in Ghana. We partnered with Kenya AIDS Vaccine Institute in Kenya, and we've also built some relationship in Nigeria, which covers east, west, north, and south of the continent. And of course, as we look to build other locations, as we start to collaborate with Dr. Petersen and his cancer group. Next slide. So that wraps up my presentation, because I want to leave some time for questions and discussion. If you guys are invested, we're raising capital currently. And so if you guys are interested in investor relation, this barcode goes to setting up a meeting with myself for investor relation, and appreciate the opportunity to present today. And thank you, Keith.
Okay, ladies and gentlemen, I know you find this information both fascinating, somewhat overwhelming, and to my colleagues here in the war room, a little bit depressing. But there's hope, right? You all represent that hope. So I want to set the framework. These two icons of healthcare are under the guidance and consult of the Federal Procurement Center and have full, not only rights and privileges, but an expectation of support in areas of funding, grants, and public sector funding. But we touched upon something yesterday about industry driving this, because government sometimes takes longer than it needs to, particularly under the data points that you've just heard. So I want to open up the floor to conversation, comments, and questions. And from an Africa perspective, tell us your perspective on what you just heard. And then I will come back with some other pointed questions to our presenters. This has been dynamic, gentlemen, and thank you so much. Opening up the floor for questions for IndyGeneUS and Dr. Petersen. And
Yes,
while go
I have a
ahead.
question in reference to, gentlemen, where does melanin play in this entire program of genome?
Melanin,
Petersen.
as in what's in our, you mean as in what's in our skin, like the melanin in our skin?
Yes.
Well, I think where it plays in is that 98% of the human genome is probably the same. It's that 2% that distinguishes us as darker-skinned people from the rest of the world. But there's a lot of information in that 2% that makes a huge difference in terms of how you treat certain diseases, whether it's hypertension, heart disease, cancer. That 2% is a tremendous amount of genetic information that distinguishes us from other people. So I don't know about the substance melanin itself, but I think if you're talking about those of us that are Black and brown who have darker skin because of melanin, it definitely plays in. I could give you example after example of diseases where how you approach them, it's very different. How you treat TB in a Black person is different than how you would start to treat in a white person. How you treat hypertension, you start differently than how you would treat in a white person. And this goes on and on and on in many, many examples. I'll give you a very simple one. Let's just take, again, I'll go back to breast cancer. Black women here in New York City routinely would have their chemotherapy interrupted because their hematocrit and their hemoglobin was too low. And they assumed it was the chemotherapy. My mother walks around at 85 with a hemoglobin of 9, and her doctors lose it. My mother has traveled to Machu Picchu. She's 13,000 feet in the air. She has no problems breathing. Has no one bothered to think, oh, gee, this woman's DNA is primarily Nigerian, and she's inherited a strong gene that protects her, and she doesn't need all that hemoglobin. But yet you would tailor therapies based on what white women need and not understanding what a Black woman would need. And that's a simple example of how, not understanding who we are and where we came from, you make decisions about our healthcare, and it has to stop, because it has a deleterious effect on our outcomes from many of these healthcare problems.
Exactly. Thanks a lot for that.
Okay, I want to know in the audience, by a raising of your hands, who's either impacted by breast cancer or, I'm sorry, strike that question. I want to know who is interested from an entrepreneur perspective, an investor perspective, being a part of the supply chain, being a part of this project. Raise your hand as it relates to your interests. I want to see those interests. Meanwhile, we will Okay. We can begin to have some open conversation, but certainly there will be follow-up. I'm happy to see the number because guess what? I really think that we hit on something. And again, I told you I've been working in Africa, not day to day, not extensively, as certainly Timothy, for example, but long enough to know that I think someone missed this whole notion of health and wealth. Without health, you have no wealth.
Correct.
This is an economic development initiative, agenda, program, and priority. We're going to learn from you who raised your hand about the leadership, the public policy, and those access points. These gentlemen have broken the mold. They are in Ghana with land. They are in South Africa with a laboratory. So if you would like to come to the mic and express your interest level, and let's get a little more granular, let's do that now. But clearly, as you've raised your hands, we're taking notes as to how to get back with you. Thank you so much. Kodzo.
Can I go first, Mr. Moore? Thank you very much.
Yes.
The
please.
first question I would like to ask both gentlemen is the incorporation of African medicine with American or white medicine. What role can it play in making sure that it is white, Mr. Petersen? I apologize. I'll just call it that. And two, processed food, exposure to processed food for us Africans, what role does it play? And thirdly, if you need access to people in government and whatever in South Africa, let me know. We can open the doors and just put in touch with Minister of Health. There's been an alarming growth in breast cancer and everything else. We've lost family members due to that, and obviously we started eating American food. McDonald's landed here, and we started having problems. I'll just be honest. That's my input for now. Yeah.
I have a lot to say, but I'm going to let Yusuf talk first because I could go on and on about this topic. Yusuf, anything you want to say first?
Yeah, for me, in terms of collaborations, we need access to government people in our country. We can open doors, we can sit down, we can do everything else. South Africa, it's a first world country in a third world continent. I'm sure you've been here. When you land, you do understand the differences. We can put you in touch with, the best universities in the country. Whatever you need, we can assist you with. But I think the first thing we should focus on what we eat, what we put on a table, and how it's prepared. And secondly, African medicine, what role can it assist in helping grow? Thank you.
Gocho, please put your email address in the chat.
Yes, so
if you're not speaking, please put on mute. Thank you so much.
Yes, I know Dr. Petersen has a lot to talk about from the health and the clinical aspect. As far as collaboration, again, I can't stress it more. Dr. Petersen and myself are two of very few across the continent. If you looked across and we did a research, it'll probably be about 5 or 6 names, and we may know all of it. Dr. Petersen and myself may know the individuals that come up across the continent. That's how small this environment is, but it's very important. So from a government collaboration standpoint, definitely, again, we're tied into Orem. Orem is a very reputable clinical research organization in South Africa, and building that ecosystem amongst the continent, because I do believe for us, our mandate is that we want to be able to build that capacity and that infrastructure, which is something that's been gravely missed as far as the continent and was exposed during COVID with the inability for us to develop vaccines and therapies for the continent. So that's first thing. As far as genetically and how we look at this, you want to think about life started in Africa, right? And so this is a premier time for Africa to stand up and be one of the leaders for the first time in modern day medicine. There's no longer the West and Europe. They have to come through Africa. And so that lays the opportunity for folks like Dr. Petersen and myself to educate these Minister of Health and the continent of how important there's an infrastructure now that's needed so that scientists and researchers like Dr. Petersen could build the infrastructure so we could do our own sequencing on the continent. We could do AI machine learning because, again, South Africa was premier for us because it had the cables and the right partnership with Microsoft. And now Google is in Kenya. So it's slowly happening, but it needs to happen faster to do some of the things that we need to do as the continent to help inform about the third one, which I know Dr. Petersen will get in, is your medicine and the health outcome, right? There's very limited screening that goes on in Africa. And if it does go on, it's shipped outside of the continent. So you think about the lack of resource and the access to some of these screening, we're seeing that our community are being diagnosed a lot later when it's stage 3 and stage 4, which are a lot more irreversible than catching it, like he said, with the example he gave. If we caught these at stage 1 and stage 2, there's a lot more you could do in longevity of life. And so I'll pause there and let him finish it out as far as, again, some of the key areas that the food that we're eating lays the groundwork for some of these aggressive cancers.
So I want to start with the whole issue of plant-based medicine. So first of all, my center is going to incorporate traditional African therapies and plant-based medicine. But plant-based medicine, you should know, already exists. Valium comes from valerian root, okay? Taxol, which is one of the biggest drugs that we use on the market for the treatment of breast cancer and other cancers, comes from a tree.
Yep.
We use a drug called Megase to help people with their appetite after having chemotherapy and they've lost their appetite. Megase uses the active ingredient of marijuana. So there are many examples of where plant-based medicines have made their way into pill form, and we're already using it. And we know because we've seen how traditionally African, Black and brown people have lived without many of these diseases, and they were doing just well. So how is that? What was there? And we need to better understand that. Now, in terms of the food that you eat, I'm actually going to say a little personal story about myself. So my father and grandfather were butchers. When we were growing up on the small island of St. Thomas, long before grass-fed and free range, you came to my father and you said, Mr. Petersen, this is what I want to cook this week, and my daughter getting married in 3 weeks, and she having 200 people, and this is what we want to eat. My father went out, found the goats, the cows, the pigs, the sheep. He caught them, killed them, slaughtered them, and that's how people ate. You ate farm to table. We didn't see all of this. And now that we're eating these processed foods and all of this stuff that's prepared for us so quickly, now we're seeing diseases presenting in a way that we've never seen before. There's a landmark paper, I'm going to get the name wrong. It came from Howard University in the 40s, looking at the trends of the American Negro and the migration from the South to the North. And what we saw in the United States is as Black people moved from the South, where they were growing their collard greens in the backyard and catching that chicken and cooking it on their own, and they moved up north to prepared food and stuff, we saw the increase in cancer and all of these other chronic diseases like heart disease, diabetes, so on and so forth. And that is contributing to these alarming rates of cancer that we're seeing on the continent, because there's a much more westernized approach to wanting to live like the developed world and the westernized approach, and it is impacting the overall health of African people because it is toxic to our system, and we've got to deal with that as well.
Dr. Petersen, there's one medicine I would like to introduce to you if you don't already know it. It's called moringa.
Yes, I know moringa.
Moringa. It's a very powerful medicine.
I have it right here.
You have moringa there. Wonderful.
Yes,
Dr.
I have
Petersen.
it right here. I bring it back from
moringa,
Africa. I bring it back on every trip.
Wonderful.
Yeah.
Yeah, listen, I want to get moringa. You got to get me some of that, Dr. Petersen.
Yeah, we need to plug that into chat. What was that called again?
Moringa, Moringa, moringa root.
Yeah. Hey,
and it even comes in a tea. You can get the tea as well.
It comes in the tea, huh? Okay. Alablasi, I butchered your name. Please tell me it. And you're on mute.
Olabisi.
Olabisi.
Hey, Kit. Hi, it's me from the X group. Thank you so much, gentlemen. And I like Gotso's input as well. I got excited. I like the way Dr. Petersen ended his quote by saying it always looks impossible from the Mandela. It always looks impossible until it's done. Because when you share your dreams, people are like, you're either crazy or you're, well. but somebody has to do it. And I'm so glad. And I'm so glad you're part of the people doing it. A bit about me. I've been in the clinical trials space for over 25 years, working in the US, in the UK, and primarily in data management. Everywhere that I've gone, traveled to in my career back then, I've always looked for, they show maps of clinical trials in the world. They talk about global data, but there was always nothing represented, really for Africa. And of course, Africa kept on calling me. So in the past few years, I became a consultant, set up my own business, and started raising workforce here in the US. We've also gone to Nigeria. I was born in Nigeria. So the African part of me kept pulling me, like, what are you going to do about it? So for the first time in over 20 years, the Society for Clinical Data Managers had their first event in South Africa in August this year. I was ecstatic. I was there. And they're like, you came all the way from the US? I said, yes, because it's important to me. And this is a dream come true. And thankfully, it will be an annual event whereby they will do it at different parts of Africa. So that's a breakthrough. We have to start from somewhere. And I'm excited about, Dr. Petersen, the village that you are building. Because another thing that I'm also doing is for my clinical research organization is we want it to be a full size, not immediately, but to have sites, to have the infrastructure, to have places where we can bring the biofarmers to, because they don't know Africa. They're afraid of Africa because they don't know. Like, we have all those things here. When I looked into the last malaria vaccine that the FDA approved, the research was done in Cameroon and African countries, but I realized the data was taken to India to be processed. I said, what? We are here. We can do it. There's a lot of us in the diaspora. And so again, what am I going to do about it? Led to me setting up a company and educating the people in Africa. So I have teams in Nigeria, in Lagos, and outside Lagos that I'm training. And we're going to spread to other parts of Africa. But we got to start from somewhere and then scale up. So thank you for what you do.
Fantastic.
Yes.
Fantastic.
Yes.
And I want to say something. Can I just say something, Keith? One of the things that excites me about what you said, Olabisi, and about what Yusuf is doing is that many people don't realize the impact that the Ukraine-Russian war had on this issue. Because where American pharma companies, people don't know this, were going for clinical trial subjects was to Europe. And because of that war, they don't have subjects anymore to participate in this. And Africa is actually the new frontier. So that's why it's a shame that our infrastructure hasn't been there, because they are hungry to come into the continent because they're looking for subjects. And we have the most diverse genetic variety than any other race of people on the planet. So it makes the kind of work that you're doing, Olabisi, and of course Yusuf, and what I'm trying to do so important right now from a generational wealth standpoint as well for the continent to drive industry and the economy on the continent.
Absolutely. Thank you.
So, ladies and gentlemen, listen, we've made a commitment to one another, right? Ubuntu. We are going to create a consortium, okay? It takes a village. And so we need, thank you, Godso, on your email address, because that's an insignia of your commitment to the support that you've offered. Olabisi, I think you are also now going to be on the list, and anyone else, put your email in the chat. If you are committed to this No Health, No Wealth in Africa campaign, we know that we have to have health in order to prosper, in order to enjoy prosperity, in order to pass prosperity down, we have to be around. And so this is a project. I want to, in the last 3 minutes we have, I want Yusuf and Dr. Petersen to basically describe, okay, we have this is a group of investors, let's say, hypothetically and conceptually, you never know. What are you saying to them? What is the offer? What is the opportunity because we will build a consortium of not only the willing, but the doing to make all of this happen. I'll start with Yusuf.
Yeah, no, I mean, I think all well said by the participant and Dr. Petersen. I think for us, you got to start somewhere. And so we were able to be fortunate to get the support of Orem, which does tremendous amount of work in Africa now. And so what we're looking to do is build that consortium, working with gentlemen like Dr. Petersen and other researchers across the continent, so we could build that consortium and have tremendous value that we could create the connectivity. When I hear about the Africa Free Trade Agreement, this should be the Africa, precision medicine agreement of us coming together and building the infrastructure. Because I think what you heard on the call today is that everyone is now invested and want to see Africa be at the forefront of precision medicine. And the opportunity to do that, like Dr. Petersen said, is right now because of some of the other issues that's going on across the different places where pharma traditionally got their participant. So one, most genetic diverse population in the world. We're going to be 2.5 billion people with it by 2050. And so I encourage all to look into what was heard and said today and join the movement, because it's going to take a village. And I think the people that came on this call today will be the first movers in helping Africa become sustainable and build their own manufacturing and drug manufacturing for their people.